Adjuvant therapy is a very important issue in the treatment of melanoma. Of course, we are dealing with early tumors and we want to prevent the evolution to metastatic disease. So we used to have interferon as the only effective adjuvant therapy, and we now have at least 4 strategies. One which has been validated in the last year, which is ipilimumab, an adjuvant strategy with high toxicity, but a very good efficacy in terms of relapse-free survival and overall survival. And we have, during this meeting, 3 trials which are basically positive, dealing either with immunotherapy, nivolumab, or with BRAF and BRAF inhibitor, with vemurafenib, or BRAF plus MEK inhibitors, dabrafenib and trametinib. They all basically are positive trials, and so, of course, the debate is going to be which treatment for which patients. And then we have to take into account a number of factors. First, these trials are focused on rather advanced disease, since they include patients with 3B, 3C, and even stage 4 patients in the adjuvant strategies. Second, we have the result for relapse-free survival, which is, of course, important, but if we look at it from the community point of view, from the societal point of view, from the payer point of view, what is important when you give an adjuvant strategy is to delay the metastatic stage. So the distant metastasis relapse-free is probably one of the best way to really appreciate the value of such a treatment. And for the moment, we don't really have this data. The second point that has to be taken into account in the decision for the adjuvant treatment of a patient is the toxicity. Of course, it's much more important when you give this treatment to a number of patients who may not need it, because that's the way we do adjuvant therapy. We treat a group of patients and only some of them are requiring a treatment. So toxicity is very important. And in terms of toxicity, the most important in adjuvant strategy is the everlasting toxicity. For instance, having a diabetes for life, for instance, is something which is hard to pay for an adjuvant strategy, but which would be quite acceptable in a metastatic setting. I think this point of view of the toxicity for the everlasting toxicity is the time to the distant metastasis, and overall, of course, the overall survival, which is the most important. For the moment, we don't have all this information, so it's difficult probably to make a choice. We have to analyze in detail all the results we have during this ESMO, but some are lacking to make a real decision.
A big point we don't now have any answer is that patients who are cured by adjuvant treatment are cured. It is definitely a big gain. Patients who are cured are still responding to the treatment in advanced disease, and the patient cured are the same or could be cured in advanced disease, or are more, or are different. We don't have yet the answer to this question. So these 3 new studies are very important. It is important to go after interferon and to increase the effect of adjuvant treatment in relapse-free survival. Finally, and most important in overall survival, but we need still more year of research and data to be sure this is not an immediate improvement, but a big achievement for the patient, because with combo treatment with anti-target treatment, we don't know what happened to the patient recurring after that. We don't know how many patients will recur after that in the next years. So you have early result at the moment.
I think that with all the doubts and all the open questions, we are living an exciting time in melanoma because finally we have effective treatments. We lived for years with a treatment who provide only 3% benefit and another treatment with important toxicity. So I think that we have to work more to understand which treatment for a patient, how to implement in routine as soon as these treatments are approved by the health regulatory agencies. But there is no doubt that this ESMO meeting is a turning point for the treatment of melanoma in the adjuvant setting, because finally we have very effective strategies, and we have several strategies and different choices in the near future. And what we have to do as scientists, as doctors who care about patients, is to select the right patients, the right treatment, and try to understand with the data we have, and thinking about the data and the results, going into the details, how to implement this great data into routine.
That will be, in fact, a problem of sequence. Do we have to treat patients early to avoid to treat them later? Or is it just better to wait for them to have a metastatic disease and then treat them? It's this comparison of two sequences which are quite possible at the moment. Either you treat early and you hope that you will save some patients from metastatic disease, or you just wait for metastatic disease, since you have tools to manage this metastatic disease. And this will be the challenge of the next years.
And fortunately, there is an ongoing clinical trials that has been powered to answer these two questions.
Yes,
these two questions.
Immunotherapy.
Is the Keynote 054 trial who was powered to answer these two important questions that has been mentioned by Dr. Grob, if it's better to give anti-PD-1 in the adjuvant setting versus no treatment, and then if we can obtain the similar overall survival by providing this type of treatment at recurrence. So I think that all the data here presented at ESMO and what we can learn in the next year with the primary endpoint of the Keynote 054 may clear the sky and make more easier also our job, and at the end of the day the treatment of our patients.